Hello everyone, welcome to 30-minute board prep. I am Dr. Anish Kurivela. I'm a practicing internal medicine physician. I work as a hospitalist in San Diego area. So this is my first video of the board prep series I will be making. A little bit about me. I actually graduated in 2019, and I took my board exam in August. I used a lot of resources to study for the ABIM, and I was able to pass the exam in the first try, and I scored pretty well as well. So, when I was studying, I used a lot of resources, like I said, and the information you need to study for this exam is extremely vast. Obviously, this is not something you will be doing in the day of the one night or one day. The knowledge you acquire during the 3 years of residency will be actually used for this exam. A lot of the things they ask in this exam are pretty straightforward. The things you would see during the your general internal medicine ward or your specialty rotation. However, a lot of the other things they'll be tested will be obscure or random facts that you probably would not have heard or seen. So that's why these videos or the board prep will be important. Also, it depends on where you're getting your training. A lot of times, if you are getting trained in a big university setting, you will be seeing more stuff, because opposed to a community hospital, you will be seeing a lot of bread and butter stuff, not the obscure things that you would see once in a lifetime, or stuff like that. So the reason for I'm making this video is to have a very informative, hopefully useful preparation that you can use, you can lay on, you can use. This will be completely free. That's another thing I want to emphasize, because when I was a resident, I know how hard is to have money to have prepare pay for your exam itself is $1,500. So there are board prep outside other you can use purchase for thousands of dollars. So I don't want to have another high payment or high make any videos with the monetary benefit. So this will be completely free, and my only intention is to make sure that you get a good preparation for the exam. If you guys like these videos, please do me a favor, please subscribe and like this video, and that will show that you give me an encouragement to make more videos like this. If you do not like this type of videos, obviously it's which is great, which is fine. Just comment or let me know what you don't like about this video, so I will try to make it up, and during the future videos I will adjust that. So that's a rant, that's over, and without any further ado, we'll be moving to the first part of this very first video of this 30-minute board prep series. So GI and gastroenterology and hepatology will be, I will start with the gastroenterology and hepatology, and we'll start from the top to bottom. We'll start with the esophagus and go down basically. All the videos are going to be 30 minutes or less than that, so nobody's going to pay attention to more than 30 minutes. So the idea is to have a videos that will be less than 30 minutes or close to 30 minutes, and we'll talk about certain topics, and we'll go over a few questions at the end of the video lecture as well. So we'll start with the dysphagia. The dysphagia is basically defined as difficulty swallowing. You need to differentiate that from odynophagia, which is basically painful swallowing. So dysphagia is a having difficulty swallowing, and which can be classified as either oropharyngeal or esophageal. Oropharyngeal is likely secondary to either some type of neurological problem, such as a stroke, or some type of muscular problem, such as muscular dystrophy or ALS or Parkinson's disease. The way you identify the differentiate between the oropharyngeal and esophageal dysphagia is oropharyngeal dysphagia, you will have difficulty initiating the starting of the swallowing part. You would also see sometimes regurgitation of the food through your nose. That's another clue you're going to look for, you will see in this type of patients. Now, this is a very high yield. How do you diagnose patients with the oropharyngeal dysphagia? You diagnose with the video fluoroscopy or your video swallow or your modified barium swallow. Those are all same things, different names for the same thing. So this is a very high yield because this is a very simple or very easy procedure you can do at the bedside or going to the lab. You do that all the time in the hospital. So patients is suspecting somebody with oropharyngeal dysphagia. The next step is not an EGD, not a manometry, not any motility studies. You actually do send them for the video swallow or video fluoroscopy, which can be, the results can be available pretty readily. So that is why this is going to be high yield, because they can test you, they can ask you. This can be asked in multiple ways. Patients come with 75-year-old comes in with the difficulty swallowing. What would be the next step? So you want to make sure that you are identifying, you're trying to rule out some type of neurological problem or some type of muscular problem. So for that, you need to do a video swallow or a modified barium swallow. Next type of dysphagia is esophageal dysphagia. There are multiple causes for the dysphagia. Esophageal dysphagia, there are multiple structural problems like esophageal web or some type of syncostrate verticillum, or you can see in some type of neoplasm or strictures or secondary to radiation or line ingestion or even GERD, achalasia. So we'll talk about a few of the esophageal causes of dysphagia in the next few slides. So this is a very classic exam question. So this is very high yield. So throughout the video series, I'm going to point out what the high yield topics are. So make sure you put an asterisk or highlight it, or somehow just know that this is going to be a very high yield. So make sure you keep note of that. So usually this is the question will be asking you, or the presentation would be a typically young male. So very young male, 25, 30, 20, or 25 or 30, 26-year-old male who presents with the difficulty swallowing, and they will report multiple histories of food stuck in the esophagus. So this is a very, very important clue. They will report multiple histories, and the food is stuck in the esophagus, and you perform the EGD because food stuck in the esophagus. The next step would be to perform an EGD, and the EGD will shows this. So they can either describe this to you, or they can show you the image. Is basically trachealization of the esophagus, or basically you will see the esophagus appear. You would, as a normal esophagus, you wouldn't see these rings or these concentric rings. In normal esophagus, it will be very smooth, unless obviously there's something's going on. So if you see something like this, or if they describe to you trachealization of the esophagus and young male with multiple histories of food stuck or food stuck in the esophagus, think about eosinophilic esophagitis. So that is a very, very high yield topic. Remember that. Now, the way you diagnose this, you need to do the biopsy. The biopsy will show more eosinophils, in more than 15 eosinophils. So that is how you diagnose it. Now, there's a trivia here. How do you treat it? So you need to one of the other diagnoses that can give you the same presentation, high number of eosinophil, is something called GERD. So GERD, or gastric is the esophageal reflux disease, is another thing, can give you the same presentation. So that's why you start with the 8 weeks of a trial of proton pump inhibitors, and if that's not working, that's how you need to rule out the GERD before treating the patient with treating for eosinophilic esophagitis. So you start with the PPI for 8 weeks, and if that's not working, then you start the swallowed steroid therapy such as budesonide or fluticasone. So this is a very, very high yield topic. Remember, put an asterisk here, or highlight it, or whatever you have to do. Just know that. Our second scenario is basically a patient comes in with dysphagia to both solids and liquids, and usually to the cold liquids, and they usually report intermittent chest pain associated with this dysphagia. And what would be the next step? So next step would be the barium swallow. So any type of oropharyngeal dysphagia, like I said, you do the video swallow. And for esophageal dysphagia, usually you're going to start with the barium swallow, unless you have something else going on. Then or then, for example, eosinophilic esophagitis, you do the EGD. So this is a very classical example. A lot of time these patients get worked up for ACS rule out. Patient comes with this diffuse pain, chest pain. So patient report chest pain. So you have to make sure that you rule out for ACS. That's obviously the number one thing. But this patient unfortunately get multiple workup for ACS and there's no diagnosis. But thing to worry about is with the cold liquids. This is precipitated by cold liquids. The next step would be barium swallow. The barium swallow would show the corkscrew appearance. So this is a corkscrew appearance, as you can see here, and multiple esophagus appears like this, and the diagnosis is this is a diffuse esophageal spasm. Now, how do you treat them? You start with the PPI, and if PPI is not getting better, you should do a calcium channel blockers. Calcium channel blocker would be the second line. The first line would be PPI for this type of therapy. Now we have an 82-year-old male who presents with difficulty swallowing. It's a history of CVA 2 years ago with some, upper extremity and lower extremity weakness. Like I said, this is an example. What will be the next step? Next step would be a video swallow. So this is an example of oropharyngeal dysphagia. You need to get a video swallow. And how do you treat this video swallow? You need to do speech therapy, dietary modification. Sometimes, the speech therapist will recommend what type of diet they're recommending. So that will be the treatment. So this is how they can ask you a elderly male or elderly female presenting with difficulty swallowing, initiating the swallowing, and will be the next step would be video swallow, or that will be the cause. Now we have another patient who comes with the intermittent dysphagia and with regurgitating undigested food. So that is an important point. Undigested food that ate in several days ago, and they also complain of severe halitosis. So this is a very, very high yield too. The reason why this is high yield, because people would diagnose this, or people would easily identify this as the Stenkus diverticulum or the pharyngoesophageal diverticulum. But how do you diagnose this? That's a very important thing. The next step is barium swallow. This is not EGD. The reason why you don't want to do an EGD in this patient, because it's a blind pouch. You don't want to insert your endoscope blindly and damage the diverticulum, damage the pouch. So you want to get a barium swallow first, and that will show something like this, and that's how you diagnose the Stenkus diverticulum. So this is also a very high yield. The high yield is how do you diagnose the Stenkus diverticulum, or how you diagnose the pharyngoesophageal diverticulum. So again, remember that the patient will be regurgitating undigested food and severe halitosis. Those are the keywords you need to remember. So a lot of times, when you take this exam, remember that you will have certain keywords on your question stem. So that's very important that you read the answers first, then you go to the questions and try to figure out question stem itself, and try to tease out what goes with the answer choices. Again, a lot of times you will have two answer choices. When I took the exam, I had two answer choices. Those were very similar, so then it's become 50-50, so it could go either way. So that's why you need to know in and out of a lot of these things, especially very high yield topics, because they will test you multiple times. So when I make the video about the oral exam, we'll go over how much is GIA and how much is multiple topics are. The GIA is about, believe it or not, about 9% of the 9% of your entire exam. So that is very important. So the 9% of the exam is GI. So that's why you need to pay attention to the GI. The next topic is usually the patient presents with a solid food dysphagia, usually meat or bread. So this is also known as steakhouse syndrome. So usually patient will be coming from eating steaks at the restaurant, and they complaints of the dysphagia that occur multiple times to time, usually from months to years. Usually occurs with the first bite, then they swallow without any difficulty. So this is very important. You need to differentiate this from the Stenkus diverticulum. In Stenkus diverticulum, the food that you ate multiple days ago will be regurgitating. They will have multiple, they will have halitosis. In the case of the esophageal ring, or Schatzki's ring, or esophageal web, the solid food dysphagia would be very episodic, and you would see that in the first bite, then without any problems. So diagnosis for this type of the next step would be in EGD with then How do you diagnose this? What's the diagnosis? Lower esophageal ring or Schatzki's ring. Another example would be esophageal web. Now, there's something you need to remember for the exam, which is esophageal web, which is something called Plummer-Wilson syndrome. You probably know it's a triplet, it's a triad of iron deficiency anemia, esophageal web, and dysphagia, and usually common in Caucasians. And the reason why you need to pick it up is there's a very high risk factor for esophageal or pharyngeal squamous cell carcinoma. Now, the way to treat the lower esophageal ring or Schatzki's ring is you do an EGD and pneumatic dilatation. Now, this is a very, very high yield topic. I cannot emphasize this is extremely high yield. Everything about this is going to be high yield, so please pay attention to this. So, a patient presents with a dysphagia to solids and liquids. That's very important. You also have regurgitation of food eaten several hours ago. Again, this is very similar to the Senkostra vertical, as you might know. Dysphagia to solids and liquids, and regurgitation to food eaten several hours ago. What is the next step? The next step would be barium swallow, and the barium swallow would show this. So this is basically show it in the barium swallow. They can describe this, or they can show you the picture. This is a dilated esophagus with a tight bird peak lower esophageal sphincter. So I usually think achalasia as opposite of GERD. Basically, GERD is wide open lower esophageal sphincter. That is why you get the acidity through the esophagus from the stomach. Achalasia is basically opposite. You have a very tight lower esophageal sphincter. So as you can see here, this is very tight, so food doesn't go through it. So this is very high yield. Like I said, the first step would be the barium swallow can show you this picture, or they can show you the picture, or they can describe this to you. And the next step would be, what is the diagnosis? Obviously, this is achalasia, so that is one way they can ask you. The second way they can ask you is, how do you confirm it? Obviously, right? So just because of manometry, is that enough? No, it's not enough. So you need to do a manometry study. So the esophageal manometry will show absence of peristalsis and incomplete relaxation of this lower esophageal sphincter with the swallow contrast. So that's very important. Now, you need to also do an EGD to rule out a pseudoachalasia, which is basically sometimes you can have some tumor blocking this lower sphincter, blocking the entire thing. That is causing this rather than the lower esophageal sphincter itself. That is why you need to do an EGD to confirm that there is no tumor block, lymphoma or type of a tumor there. So you need to do all these three: barium swallow, esophageal manometry, and an EGD to confirm that there is no to confirm that it's achalasia. Now, how do you treat this? The first line is laparoscopic myotomy with a partial fundoplication of the LES. That will be the first line. And if you can also do laparoscopic pneumatic dilatation. So these are all first line. Either you do the myotomy or you do the pneumatic dilation. The second line is botulinum injection. Again, this injection usually doesn't last for long. You need to have multiple injections, usually about 6 months or so. So that is why second line. And if the patient is not a surgical candidate, you have to use the third line, which is calcium channel blockers or nitrate. Once again, please make a note of the diagnosis, the barium swallow the picture itself, which is probably a lot of people know. This is pretty common in a classic picture. But the main thing you wanted to take home point is that you need to do all this thing. EGD has to be done before saying that it's achalasia, because the tumor is one of the things that you want to rule out, and manometry, and this is going to be, again, I cannot stress this enough, very high yield. Next patient is with a history of GERD, long-standing GERD, or the report history of suicide attempt or something with a lye ingestion, or history of radiation, a cancer patient, or you have an eosinophilic esophagitis, the patient we saw earlier, who comes in with a progressive solid food dysphagia. The next step is definitely the barium swallow. The barium swallow would show this type of picture, the esophagus. You can see here there are multiple narrowing here, and this is basically the esophageal stricture. How do you diagnose this? Obviously with the barium swallow. And how do you treat this? With the EGD and dilation. All right, so now we're going to move into our second subtopic. It's called odynophagia. So odynophagia, by the name itself, it is the known as painful swallowing as opposed to difficulty swallowing. So when you do the HMP or when you do the examine the patient, make sure that you differentiate between these two. Is it painful or if it's difficulty? Again, your differential diagnosis is going to be different, both those two. Again, patients sometimes can have both, but you have to identify which one patient has. Now, the most common odonophagia is the most common presentation of esophagitis. What are the causes of esophagitis? You can say the most common is you have infectious causes, which is your most common cause is candida or candida infection is a very common cause of odonophagia or esophagitis. Your CME infection or cytomegalovirus or HSVs are the other two infectious sources. Pretty common is pills. Your tetracyclines, your doxycycline. A patient will be coming in for taking treatment for Lyme disease or some type of lower extremity cellulitis or something, and they then comes in with this painful swallowing. So remember that tetracyclines are notorious for causing odonophagia because the pill stuff is very big and can cause inflammation in the esophagus. And such the iron pills or alendronate patients who osteoporotic patients, or your KCl, potassium chloride, those are the other things. And the third one is radiation is another reason why you can get odonophagia. With pill-induced, you would see severe substernal pain with swallowing that occurs several hours to days after taking the medication. So you need to go dig deep and make sure that they're not taking this medication that causing the pain when they swallow. We'll go one question here. So this is going to be a typical question. A 32-year-old female with a history of HIV presents with 1 month of odonophagia or painful swallowing, and on exam you note oral thrush. So what is the next step? So this is an important concept you need to know. And usually, if you think that patient has odonophagia, you want to make sure you do an EGD. But in this case, we almost certain that patient has a oral candidiasis. So you start the empiric treatment with fluconazole. There is no EGD needed. Again, this is a high yield topic. You need to know this. This is based not on oral thrush. This is based on the HIV or immunocompromised patient. So if an immunocompromised patient comes with odonophagia, you can empirically start them with fluconazole. And if that is the first step. And if that is not working, what would be the next step? You need to do an EGD to rule out either CMV, HSV, or even the the resistant Candida infection. So if you see a oral thrush, obviously that is another clue that this is oral Candida. But for all practical purposes, or even for examination, if you see an immunocompromised patient with odonophagia with no other risk factors or no other pills, radiation, anything like that, you can start empirically on fluconazole and evaluate the patient. If they're responding, great. You would treat it the fluconazole, the Candida. If it's not, then obviously next step would be an EGD. That is very high yield topic for your exams too. Now we're going to talk about a few infectious etiologies for the odonophagia. So the very first one, like here, is the one we already discussed. This is the oral thrush patient and multiple white plaques on the EGD. So this is basically your Candida esophagitis. The way you treat it, you start with the fluconazole or the itraconazole. This one is, basically you can see multiple ulcers. This is your HSV esophagitis, and the way you treat is with the acyclovir or famciclovir. Last but not least is a single large ulcer. You can see here, that's basically secondary to the CMV. The way you treat it with the ganciclovir or foscarnet. Again, the treatment options are very, I would say, medium important. It is to know, especially for the these ones. Now, with that being said, we're gonna have to go through the practice questions. So let's talk about, we'll have a few questions here to go over. We have a 26-year-old African-American female complains of intermittent difficulty swallowing solids and liquids. He also reports food regurgitation she also reports food regurgitation several hours after eating. An examination unremarkable. A barium swallow shows dilated esophagus with tapering gastroesophageal junction, and EGD is unremarkable. And which of the following is most likely the diagnosis. So again, this is a very important question. So I'm gonna, before I, answer the question. So I'm in my questions, I'm going to focus on. This is not going to be the typical question format you're going to see for the ABIM exam, because they're not going to give you all the information and be like, hey, here, figure it out. The reason why I'm making this type of questions is to reinforce the high yield topics, the high yield the words associated with the diagnosis, so that when you do the exam, when you take the questions or when you do the exam, that will stick out to you. So again, 26-year-old African American male, intermittent difficulty swallowing to solids and liquids. Okay, so this is pretty much sounds like this is could be diffuse esophageal spasm, right? But again, that's usually can be called Syncytial reticulum, probably not. Eosinophilic esophagitis, the age matches. So far we don't know. Several hours after eating, so probably not syncytial reticulum, right? Syncytial reticulum is usually reported agitation after several days. Exam unremarkable. I guess, I don't know when was the last time the exam was remarkable. Barium swallow shows, this is the money. Barium swallow shows dilated esophagus with the tapering gastroesophageal junction, and EGD is unremarkable. So again, that is pretty much tells you that this is the bird peak appearance, or the answer would be achalasia. Now you need to make sure that you do a manometry and an EGD before starting the patient, treating the patient. So that is a very high yield. This is a very high yield topic. Again, those are the things you need to know too before proceeding with the treatment. Number 2, if a 51-year-old female with a history of liver transplantation is being evaluated for painful swallowing for a week, pain is worse with both solids and liquids. On exam, no oral thrush is noted. Subsequent EGD shows multiple white raised plaques. Biopsies were taken, and which of the following is the best treatment? Again, they actually went to with the EGD. Sometimes you don't have to, sometimes they don't treat with the antifungal medication. They actually, do EGD. Here the patient they already did the EGD for you. So you do acyclovir, or you do foscarnet. You have swallowed budesonide, fluconazole, or swish and swallow nystatin. Now, so the answer is obviously the fluconazole. Now, I'll let you point, obviously, acyclovir is used for the herpes. Foscarnet is used for the CMV. Swallowed budesonide is used for the eosinophilic esophagitis. And swish and swallow nystatin, this is a very important topic. So if the patient has, oral cannula, you can do the swish and swallow nystatin. If the patient has the esophageal candida, you have to treat with the fluconazole. You cannot just do the swish and swallow nystatin. Next question. A 22-year-old male presents with a food stuck in his esophagus. Patient reports this happened 3 times before, and upper endoscopy shows food bolus in the esophagus. After removing the food bolus, esophagus appears stacked concentric rings. Biopsies were taken, and what is the best next step? Again, or what is the diagnosis here? The diagnosis here is obviously we have a 22-year-old young male who presents with the food stuck in his esophagus, and you have you report multiple episodes in the past. So this is basically your eosinophilic esophagitis, the classical picture of eosinophilic esophagitis. The way you treat would be PPI for 8 weeks, followed by, if it's not working, obviously to rule out the GERD. If that's not working, then you do eosinophilic esophagitis. But that would be the inhaled steroids. That would be the next step. Question number 4 is, you have a 72-year-old female who presents with a dysphagia for 2 weeks. And daughter at the bedside is actually giving the history. She states that when the patient eats, she coughs after the first bite of food. And examination is with the tremor and shuffling gait. What is the next step to evaluate the dysphagia? So again, this is a type of, what type of dysphagia? This is oral, or this is esophageal? This is oral dysphagia, right? So how do you diagnose oral dysphagia? That's how the question come out to be. Basically, video fluoroscopy or barium swallow, modified barium swallow. That is how you diagnose the oropharyngeal dysphagia. You don't need to do an EGD or barium swallow is the other regular BAM swallow, manometer, careful. Obviously, you don't want to just careful monitor her. She's 72-year-old. She's gonna have multiple multiple aspiration events if you just ignore this. So that's very important questions too. So with that being said, this is our last question. So that's it for the GI dysphagia part. I'll be making more topics pretty soon, hopefully in the next few days. Again, this is my off week, so I'm trying to make as much as videos I can. I know you have an exam coming up in August, so we'll try to make a few videos every week and try to upload it. If you guys like this video, just give me a thumbs up. Please subscribe to my channel. That way I know this is being you guys like this. If you don't like it, just like I said before, please let me know why you don't like it, the things I can improve. I know I talk really fast, so you don't have to fast forward the video in 1.5 or 1.7 speed. I am actually talking in 1.5 speed right now, so if that's need to be changed, I can obviously talk a little bit slower, but if you need to see more content, more pictures or more questions, if you like to have different type of questions, just let me know. If you like to, obviously collaborate with me or, help, have more videos, produce more videos, also please let me know. I will be, you can reach out to me at any, you can just contact me at any ways. Other than that, I will see you next time. Thank you for watching.